everyone, and thank you for taking the time to view this video recorded lecture on the autonomic nervous system. Having a solid understanding of the autonomic nervous system is absolutely essential to the practice of anesthesia, and brushing up on it over the summer will allow you to devote more of your time in the program to learning the principles and practice of anesthesia. I'm sure you're all aware that it's the anesthetist's job to render patients unconscious for surgery. But what you may not be aware of is that we have many roles besides inducing unconsciousness. It's also our responsibility to keep the patient safe during surgery. Part of keeping the patient safe is managing the patient's hemodynamic response to the trauma being inflicted by the surgeon's knife. Just because our patients may be unconscious does not mean the patient's nervous system won't respond to pain inflicted by the surgery. As nurses, you know that our bodies have multiple defense mechanisms that spring into action when we perceive or experience a real threat. While those defense mechanisms are designed to help us survive, they can also sometimes cause harm. Without intervention, a patient is likely to become tachycardic and hypertensive when the surgical incision is made. If that patient happens to have coronary artery disease, the tachycardia and hypertension caused by surgical incision can lead to myocardial ischemia or infarction. So it's up to us as anesthetists to anticipate and intervene to prevent this from happening. The overall objective of the nervous system is to sense what's going on inside the body and in our environment and to relay that information to the brain where it can be processed and a decision can be made about how the body should respond. Sensory information is picked up by receptors either in our internal organs, the visceral sensory division, or on our muscles, skin, and joints, the somatic sensory division, and carried to the central nervous system, the brain and spinal cord. The central nervous system integrates that information and makes a decision about how the body should respond. Motor impulses are then sent back out by way of the motor division of the peripheral nervous system to cause either a voluntary skeletal motor response, like moving away from the threat, or to cause involuntary changes in our visceral organs, the heart, lungs, blood vessels, and glands. It's this involuntary visceral motor response that we seek to anticipate and control pharmacologically during surgery. This visceral motor division of the nervous system is termed the autonomic nervous system and can be further subdivided into the sympathetic and parasympathetic nervous systems. Practically every drug used in anesthesia has some effect on heart rate, cardiac output, blood pressure, and vascular tone. Having a solid understanding of the anatomy and physiology of the autonomic nervous system, the organs innervated, the neurotransmitters, and the receptors will give you a huge head start to understanding the pharmacology of anesthetic agents and other frequently used drugs in anesthesia. Just to emphasize the difference, the somatic motor division of the nervous system is responsible for those things that are within our voluntary control, our skeletal muscles, skin, and joints. This is where our neuromuscular blockers will come into play, but this is not involving the autonomic nervous system. The autonomic nervous system is mostly a motor system. It's called the general visceral efferent system. General meaning that it's involved with our general senses, not our special senses like our sight and our hearing. Visceral means it involves our internal organs. Efferent means it's involved with signals being transmitted away from the central nervous system. So the autonomic nervous system controls those things that we do not have voluntary control of, our smooth muscles, glands, and our myocardium. And another way to look at the autonomic nervous system is that it innervates all innervated structures in our body except neuromuscular junctions of the skeletal muscle. Before we get too much further into this, I need to make sure that you have the definitions of some terms that I plan to use. Neurotransmitters are the chemical messengers, the chemicals that are released from a neuron into the synaptic cleft. They diffuse across the synaptic cleft and bind with receptors on the target tissue to cause something to happen. So neurotransmitters are chemical messengers. Receptors are the protein molecules either on the surface of a cell membrane or integral to the cell membrane on which the neurotransmitter and other substances will bind to cause a change in the activity within the cell. And the word effector refers to the tissue or the organ on which the neurotransmitter is going to have its action. Going back to the neurotransmitters, the autonomic nervous system is divided into the sympathetic and parasympathetic nervous systems, and each of these divisions has a specific set of neurotransmitters that are synthesized and released from the neurons within that nervous system. The neurotransmitter synthesized and released in the parasympathetic nervous system is easy to remember because there's only one, that is acetylcholine. The sympathetic nervous system is responsible for synthesizing and releasing three different neurotransmitters or chemical messengers. They are acetylcholine, epinephrine, and norepinephrine. I'm going to spend a fair amount of time on this slide. I really like this slide. It kind of shows you the big picture. It puts everything together for you. Starting on the left-hand side, in the area that's shaded tan, that represents the central nervous system, the brain and the spinal cord. This is showing you that the origins of the neurons in both the somatic nervous system and the autonomic nervous system is within the brain or the spinal cord, within the central nervous system. Starting with the somatic nervous system, it's a single neuron, which makes it easy to remember. Its cell body is located within the central nervous system, either the brain or the spinal cord. It has a heavily myelinated axon that extends all the way from that cell body to the effector organ. The neurotransmitter in the somatic nervous system is acetylcholine. It's synthesized within the neuron and released at the nerve terminal. The acetylcholine then diffuses across the synapse and binds with receptors on the skeletal muscles. Once acetylcholine binds with the acetylcholine receptors on the skeletal muscle, a stimulatory effect occurs and the skeletal muscle contracts. This is very simplified. You will learn a lot more about the synthesis and release of neurotransmitters in your physiology course within the program. But our purpose here is just to give you an introduction to the autonomic nervous system, and in this case, we're contrasting it with the somatic nervous system. Moving down to the autonomic nervous system, both the sympathetic and parasympathetic divisions of the autonomic nervous system are two neuron chains. Again, the cell bodies or the origin of the neurons within both the sympathetic and parasympathetic nervous system is within the brain or spinal cord in the central nervous system. In the sympathetic nervous system, the first neuron in the two-neuron chain is a short neuron, and the second neuron is a longer neuron. The neurotransmitter synthesized and released from the first neuron, it's called the preganglionic neuron, is acetylcholine. The postganglionic neuron within the sympathetic nervous system synthesizes and releases the neurotransmitter norepinephrine. Norepinephrine then diffuses from the nerve terminal of the postganglionic neuron, binds to receptors on the effector organ, the effector organs being the smooth muscle, glands, or cardiac muscle. A difference between the somatic and the autonomic nervous system is that when the neurotransmitter is released by the postganglionic neuron, the response can either be stimulatory or inhibitory. We have a tendency to think that when our sympathetic nervous system is activated, that all the responses are stimulatory, but as we proceed through the rest of this presentation, you will understand that not every organ is stimulated when norepinephrine is released. Some organs, the organs that we don't need in a fight or flight situation, are actually inhibited. The diagram is showing you two neurons in the sympathetic nervous system. The first neuron is generally a short neuron. The second neuron is generally a longer neuron. There are always exceptions, unfortunately, but as a general rule, you can remember sympathetic nervous system has a short preganglionic neuron and a longer postganglionic neuron. That the neurotransmitter released from the preganglionic neuron is acetylcholine, and the neurotransmitter released from the postganglionic neuron is norepinephrine. But the second situation that they've demonstrated or depicted in this slide is the situation of the adrenal medulla. In this situation, the preganglionic neuron of the sympathetic nervous system does have its origin in the central nervous system, and a myelinated axon extends out directly to the effector organ. The neurotransmitter released from this preganglionic neuron is acetylcholine, but acetylcholine in this situation is released directly to the effector organ. The effector organ is the adrenal medulla. The adrenal medulla synthesizes epinephrine and norepinephrine, and it releases norepinephrine and epinephrine into the bloodstream. So in the exception or the situation of the adrenal medulla, there is a preganglionic neuron which extends from the central nervous system. It releases acetylcholine that is the same, but the adrenal medulla itself is acting as the postganglionic neuron. It is releasing the neurotransmitters, epinephrine and norepinephrine, directly into the bloodstream, where it will travel throughout our systemic circulation and have its effect on multiple effector organs. The parasympathetic nervous system also is a two-neuron chain with its cell body in the central nervous system and a myelinated axon exiting the central nervous system extending into the periphery. The neurotransmitter released from the preganglionic neuron is again acetylcholine. Acetylcholine diffuses across the synapse, binds with receptors on the postganglionic neuron, and in the situation of the parasympathetic nervous system, the neurotransmitter released from the postganglionic neuron is also acetylcholine. In the parasympathetic nervous system, as a general rule, the first neuron is a longer neuron and the second neuron, or the postganglionic neuron, is a shorter neuron. But the neurotransmitter from both neurons in the parasympathetic nervous system is acetylcholine. Acetylcholine then diffuses across the synapse, binds with the effector organ. In many cases, it's the same effector organs that are innervated by the sympathetic nervous system, and the result can be either stimulatory or inhibitory depending on what that effector tissue is. I didn't define the word ganglion for you, but the word ganglion just refers to an area where nerves come together and synapse. Oftentimes it's more than just two neurons coming together. There's often a group of neurons that come together and synapse in an area, and it appears as a swollen area along the pathway of the nerve, and that is what a ganglion is. So now that we've figured out which neurons synthesize and release which neurotransmitters, and that the neurotransmitters are being released to an effector organ where they will bind to a receptor, we need to now concentrate on what those receptors are. Receptors are proteins, either on the surface or they're integral proteins within the cell membrane of the receiving tissue, and the receptors in the sympathetic nervous system are termed adrenergic receptors. Adrenergic because they respond to adrenaline, epinephrine, and norepinephrine. So those receptors that receive norepinephrine and epinephrine and cause a sympathetic response are adrenergic receptors. There are 4 subtypes of adrenergic receptors: alpha 1, alpha 2, beta 1, and beta 2. Within the parasympathetic nervous system, acetylcholine is the neurotransmitter released to the effector tissue. Therefore, those receptors are termed cholinergic. If the receptor responds to acetylcholine, it is a cholinergic receptor. There are subtypes of cholinergic receptors, nicotinic and muscarinic. Nicotinic receptors respond to nicotine. Muscarinic receptors respond particularly to muscarine. And there are 5 different subtypes of muscarinic receptors, M1, M2 through M5. Most of our internal organs are innervated by both the sympathetic and the parasympathetic nervous system. And which one is going to be dominant at any particular time depends on what our central nervous system is perceiving about our situation. The sympathetic nervous system is going to be more heavily activated in a situation where your body is threatened, and we term it a fight, flight, or fright situation where you're under a lot of stress or you're in a lot of pain. The central nervous system is going to increase the sympathetic outflow. In situations where the central nervous system is not perceiving a threat, the parasympathetic nervous system will be more predominant. The parasympathetic nervous system is termed our rest and digest nervous system. The parasympathetic nervous system is more dominant when we're resting, when we're sleeping at night, when you're comfortable and conserving energy. There is another division of the autonomic nervous system. It's termed the enteric nervous system. It is totally focused on the GI tract. I'm not going to talk about the enteric nervous system in this presentation. You may talk about it some in your anatomy and physiology course in the program, but the enteric nervous system is very heavily influenced by the sympathetic and parasympathetic nervous system, and we will talk about the receptors and the influence of both the sympathetic and parasympathetic nervous system on the GI tract as we move forward. The specific area of our brain that's responsible for controlling the autonomic nervous system outflow is the hypothalamus. The hypothalamus takes in information from many areas of the brain. The occipital visual cortex sends information. The auditory cortex sends information. The limbic cortex, which is responsible for survival and perpetuation of the species, memory, the sense of smell. All of these areas of the brain send information about our perceived situation in our environment to the hypothalamus. The hypothalamus then makes the decision about whether to increase or decrease the outflow of the sympathetic and parasympathetic nervous system, which results in an increased activity of useful tissues and a decrease in the activity of the tissues that aren't useful, depending on what the perceived situation is. We said earlier that both the sympathetic and parasympathetic nervous systems originate in the central nervous system, meaning that the cell body of the preganglionic neuron in each division exists in either the brain or the spinal cord. This slide shows you exactly within the central nervous system where the sympathetic and the parasympathetic fibers originate. The parasympathetic nervous system is termed the cranial sacral nervous system, meaning that the cell bodies of the preganglionic fibers originate either in the brain or in the sacral spinal cord. There are no parasympathetic nervous system preganglionic fibers originating in the cervical, thoracic, or lumbar spinal cord. Remember, we said that in the parasympathetic nervous system, generally the preganglionic neuron is a long neuron and the postganglionic neuron is a short neuron. Contrast that with the sympathetic nervous system. The sympathetic nervous system is termed the thoracolumbar nervous system. You'll notice here that there are no preganglionic sympathetic fibers originating in the brain or the sacral spinal cord. The sympathetic preganglionic cell bodies are located in the thoracic and lumbar spinal cord. Within the sympathetic nervous system, the preganglionic fibers are generally short fibers and the postganglionic fibers are long fibers, which results in the sympathetic chain ganglia, which line up right alongside of the thoracic and lumbar spinal cord. Another thing that this slide demonstrates is that the sympathetic and parasympathetic divisions of the autonomic nervous system in general oppose each other. So when you look at, let's say, the pupils, for instance, the pupils are innervated by both sympathetic and parasympathetic fibers. When the sympathetic fibers are stimulated, the pupils dilate. When the parasympathetic fibers are stimulated, the pupils constrict. Moving on down to the heart, when the sympathetic fibers to the heart are stimulated, the heartbeat accelerates. When the parasympathetic fibers to the heart are stimulated, the heartbeat slows. So in general, the sympathetic and parasympathetic divisions of the autonomic nervous system oppose each other. This slide represents a cross-section of the spinal cord in the thoracic or the lumbar level. Gray matter, as you see in the center here, in kind of a butterfly shape, gray matter is a collection of cell bodies. White matter is a collection of axons. I know that this is a thoracic or lumbar level spinal cord cross-section because the preganglionic sympathetic cell bodies are located in the intermediolateral gray matter of the spinal cord and the thoracic and lumbar areas. Just a little bit of review about the adrenal medulla. The adrenal medulla is also part of the sympathetic nervous system. It's supplied by a preganglionic sympathetic fiber, which has its cell body in the intermediolateral gray matter of the spinal cord in the thoracic and lumbar levels. That preganglionic fiber releases acetylcholine onto the adrenal medulla. The adrenal medulla then acts as the postganglionic fiber, releasing epinephrine and norepinephrine into the central circulation. That epi and norepinephrine circulates then through the systemic circulation and has effects on multiple organs throughout the body. The percentage of epi and norepi released from the adrenal medulla is 80 to 85% epinephrine, 15 to 20% norepinephrine. So the sympathetic nervous system releases norepinephrine from its postganglionic neurons, and it releases both norepinephrine and epinephrine from the adrenal medulla, but the majority is epinephrine when it's coming from the adrenal medulla. Putting the events together, when your body is under a threat, for instance, someone sneaks up on you in a dark alley or a surgeon's knife cuts your skin, your body, whether it's conscious or not, will still perceive that you're threatened. Your cerebral cortex then will send signals to your hypothalamus, either from what you see, what you hear, the pain you're experiencing. The hypothalamus then makes a decision that yes, indeed, your body is being threatened, and it sends signals down the spinal cord to activate the sympathetic nervous system. Those signals being transmitted down the spinal cord do not send any information out to the periphery until they get to the thoracic and lumbar spinal cord, because that's where the sympathetic preganglionic fibers are. The sympathetic preganglionic fibers reach action potential, and action potential is propagated down their axons. Their acetylcholine neurotransmitter is released into the synapse at the ganglion, mostly in the paravertebral sympathetic chain ganglia. However, there are some other sympathetic ganglia. The postganglionic neurons then are activated. Action potentials reached on the postganglionic sympathetic fiber, which causes the postganglionic fiber to release its neurotransmitter norepinephrine into the synapse at the effector organ. That norepinephrine diffuses across the synapse, binds with the adrenergic receptors on the effector tissue, and those adrenergic receptors could be alpha-1, alpha-2, beta-1, or beta-2 subtypes, but norepinephrine does bind to those receptors and causes some change in the tissue. Remember, it could be a stimulatory change, or it could be an inhibitory change. Activation of the preganglionic sympathetic fibers in the spinal cord also cause release of acetylcholine onto the adrenal medulla. The adrenal medulla then releases epinephrine and a little bit of norepinephrine into the central circulation. The epinephrine circulates. It also attaches to adrenergic receptors on effector tissues throughout the body, and tissue activity adjusts. So now that we know where the sympathetic and parasympathetic fibers originate, where they synapse, what neurotransmitters are released, we need to move on to looking at the receptors that the neurotransmitters bind with. Which receptors are predominant in which tissues, and which receptors are present in which tissues. This particular chart was copied from the Pharmacologic Basis of Therapeutics by Goodman and Gilman, but any physiology textbook will have a chart very similar to this. It just goes through all of the organs and tissues innervated by the sympathetic and parasympathetic nervous system. It tells you which receptors are located in which effector tissues, and it also gives you information on which receptors are predominant in given tissues. What happens when that receptor is bound by its neurotransmitter? Is it an inhibitory or a stimulatory effect? When I was a student, this is how we were asked to remember this information. We were given these charts, and we were asked to memorize the receptors, the tissue types, whether things were stimulated or inhibited, and actually the number of plus signs in the second column there. We considered it cruel and unusual punishment. So since that time, I've tried to come up with a better way to help students really learn this material without having to memorize these charts. So here we go. Here's a method that I've found that I think really will help you and has helped me remember which tissues are stimulated when sympathetic outflow increases and which tissues are actually inhibited. When you're in a fight or flight situation, you need some tissues to rev up and increase their activity. There are other tissues that you don't want to waste the energy on, so you would stimulate the tissues that will be helpful in a fight or flight situation, and you would inhibit tissues that are not helpful in a fight or flight situation. All tissues stimulated in a fight or flight situation by the release of epinephrine and norepinephrine will have predominantly alpha-1 receptors. There are 3 exceptions. There are 3 tissue types that we want to stimulate in a fight or flight situation. So when epinephrine or norepinephrine binds to these tissues, they are activated and their activity increases, but they are not predominantly serviced by alpha-1 receptors. They are the exceptions: the heart, the juxtaglomerular apparatus of the kidneys, and fat cells or lipocytes will have beta-1 receptors predominantly. On the inhibition side, all the tissues that we desire to inhibit in a fight or flight situation have predominantly beta-2 receptors, with a couple of exceptions. They are presynaptic nerve endings, and some parts of the gastrointestinal tract will have alpha-2 receptors predominantly. Remember, we're just talking about the sympathetic nervous system here. We'll talk about the parasympathetic nervous system and the cholinergic receptors later. But let's walk through a few tissues and see if this system works. If the tissue is helpful in a fight or flight situation, we would stimulate it, and the predominant receptors would be alpha-1, with our 3 exceptions: the heart, juxtaglomerular apparatus, and the fat cells. If the tissue is not helpful in a fight or flight situation, we would inhibit it. The predominant receptors would be beta-2, with a couple of exceptions: presynaptic nerve endings and some parts of the gastrointestinal tract would be supplied predominantly by alpha-2. So starting with our skin. In the cartoons, whenever someone is in a threatening situation, they always show the person with their hair standing straight up on end. But we also know that the hair on our extremities stands up, or our erector pili muscles are stimulated in a fight or flight situation. You may ask, how is this helpful to us in a fight or flight situation? Well, it's a stretch, but you have to go to lower animal forms. And lower animal forms, when a dog is threatened, you'll see its hair stand up on its back. And this is a way of, it's a defense mechanism for the animal to look bigger against whatever it is that's threatening it. So, in a fight or flight situation, we want our erector pili muscles to be stimulated to contract to make the hair stand on end. Therefore, the predominant receptors are alpha-1. Moving on to the eye, there are 2 situations in the eye we need to look at. First are the radial muscles. The radial muscles are the muscles that contract and dilate our pupils. In a fight or flight situation, do you want to allow more light into your eyes or less light into your eyes? Of course, you need more light in a fight or flight situation so that you can prepare to run, so that you can see where you're going to if you're going to flee the situation. Therefore, we want to stimulate the radial muscles, because when the radial muscles are stimulated, they contract and they open up the iris. Therefore, the predominant adrenergic receptors in the radial muscles of the eye are alpha-1. The ciliary muscles of our eyes are responsible for changing the shape of the lens to accommodate for near and far vision. In a threatening situation, you want to be able to see far out in the distance. In case you're planning to run or flee the situation, you need to see far ahead of you. I'm going to move on to the next slide here so we can take a closer look at the function of the ciliary muscles. In the upper diagram, you can see here that the ciliary muscles are relaxed. Remember, when muscles are relaxed, they're long. When muscles are contracted, they're shortened. So in the upper diagram, the ciliary muscle is actually relaxed, and the arrows are showing you that pulls the ligaments attached to the lens posteriorly, which actually stretches the lens, and the stretched out flatter lens is better for seeing far in the distance. In the lower diagram, the ciliary muscle has contracted, it's shortened, it's moved forward and caused less tension on the lens, which allows the lens to take on a more globular shape and accommodate for near vision. Therefore, going back, we want to inhibit the ciliary muscles, which allows for the lens to be stretched and flattened so that you can accommodate for far vision in a fight or flight situation. So the predominant receptors in this tissue being inhibited are beta 2. What do we need to happen in our lungs in a fight or flight situation? Well, if we're preparing to run away, we need to dilate our bronchioles so that we can move more air in and out. We can get more oxygen into the tissues and remove the carbon dioxide that we're generating. Remember, when muscles are stimulated, they contract, and when bronchial smooth muscles contract, the lumen of the bronchioles narrows, so we need the bronchial smooth muscles to relax. Therefore, we need the bronchial smooth muscles to be inhibited, and when a tissue is inhibited, the primary receptor, adrenergic receptor, is beta 2. Mast cells contain histamine and other vasoactive substances that are released in an anaphylactic or an anaphylactoid situation, and we know that histamine causes bronchial constriction. We don't want bronchial constriction in a fight or flight situation, therefore we need to inhibit the mast cells. Inhibiting the tissue tells us that the primary receptors there are beta 2 receptors. As far as blood flow to the lungs, of course we need more blood flow going past the alveoli so that we can exchange oxygen for carbon dioxide. But that's a function of heart rate and stroke volume, or a function of cardiac output. If the arterioles to the bronchioles dilate, more blood flow will be brought in, which can cause hyperemia and increased interstitial fluid, increased accumulation of secretions in the lumen of the airway, and can actually restrict the flow of gases and decrease the lumen of the airway. So we don't want to bring extra blood flow into the bronchial blood vessels, the bronchial arterioles. Therefore, we want to stimulate the smooth muscle in the bronchial arterioles, and stimulating tissues as a result of alpha-1 stimulation. This slide represents arteriolar blood flow to each of these organs in a fight or flight situation. Starting with the skin, it's not going to be helpful to us to increase the arterial blood flow to the skin in a fight or flight situation. Therefore, we want to constrict the blood flow to the skin, which means we want to constrict the arteriolar smooth muscles. We want to stimulate the arteriolar smooth muscles to constrict the vessels. Therefore, the primary receptors are alpha-1. When it comes to the coronary arteries, of course, we want to bring more blood flow to the coronary arteries in a fight or flight situation because we're already asking the heart to increase its heart rate and force of contraction. So we want to increase the blood flow to supply the heart with the oxygen and nutrients that it needs. Therefore, we want to relax the smooth muscles in the coronary arteries. Relaxing is consistent with inhibition of the arteriolar smooth muscles, and therefore the adrenergic receptors that are predominant in the coronary arteries are beta 2. Blood flow to the gut is not going to help us in a fight or flight situation. Therefore, we want to constrict the blood vessels. We want to stimulate the smooth muscles in the arterioles to constrict the arterioles and decrease the blood flow. The primary receptors are going to be alpha-1. To the skeletal muscles, we want to increase our blood flow to the skeletal muscles so we can run away from the threat. Therefore, we want to relax the arteriolar smooth muscles and increase or dilate the blood vessels. So we're inhibiting the arteriolar smooth muscles by stimulating beta 2. Blood flow to the kidneys and to the brain are primarily autoregulated. They're regulated by local factors more so than they're regulated by autonomic nervous system stimulation. The kidneys, the arterioles to the kidneys have alpha-1, alpha-2, beta-1, and beta-2 receptors, but again, it's not the sympathetic or parasympathetic stimulation that really regulates the renal blood flow. It's mainly autoregulated, And the same with the brain. Blood flow is primarily autoregulated. However, there is a slight alpha-1 influence which slightly constricts the arteriolar blood flow to the brain in that fight or flight situation. Probably not much of a factor. Stimulating the smooth muscles in the veins will cause a decrease in the lumen of the veins. When you constrict the lumen of the veins, there are valves in veins. The blood can only flow in one direction. By constricting the lumen of the vein, you're increasing the venous return to the heart, which is going to increase cardiac output, which is all very useful in a fight or flight situation. So what do we want to do with the smooth muscles in the veins? We want to stimulate the vascular smooth muscle, and stimulating is the result of alpha-1 adrenergic stimulation. Now we've come across the first exception to our rule. Remember in the beginning we said if a tissue was going to be helpful to us in a fight or flight situation, we would stimulate it and that the primary receptors would be alpha-1, but there are three exceptions. The first exception is the heart. The heart is definitely useful to us in a fight or flight situation, so we do want to stimulate its activity, but its primary receptors are beta-1 receptors. Beta-1 receptors in the cardiac conduction system increase chronotropy, increase dromotropy, and increase inotropy. The release of norepinephrine by adrenergic fibers on the SA node increases the rate of firing of the SA node and increases heart rate. The release of norepinephrine on the AV node increases its firing rate and decreases the conduction delay between the atria and the ventricles, and the release of norepinephrine on the ventricular myocytes increases their force of contraction or increases inotropy. All of these are attributable to beta-1 stimulation. So when you're thinking about the heart, you're primarily thinking about beta-1. Okay, you've just been confronted by a stranger in a dark alley. What do you need your GI tract to do to help you in this situation? Well, you don't need to be expending energy on digestion and peristalsis. So the sympathetic nervous system stimulation, the release of norepinephrine, is going to bind to alpha-2 receptors in your GI tract and cause inhibition of both secretion and peristalsis. Beta-2 receptors are also present in your GI tract. It's a combination of alpha-2 and beta-2 adrenergic stimulation that inhibits peristalsis. Now, your sphincters are a different story. You want your sphincters to contract because this is not the time to defecate. You're getting ready to run and flee the situation, so we need to stimulate the smooth muscle of your sphincters in your GI tract to contract so that you don't stop and defecate. So we're stimulating the sphincter muscle tissue. Stimulation is a result of alpha-1 adrenergic stimulation. This is also not the time to be urinating. So we need to inhibit the detrusor muscle, which is the muscle that causes us to empty our bladder. Inhibition is the result of beta-2 adrenergic stimulation. And the same thing goes with sphincters for our urinary bladder. We want to stimulate the smooth muscle of our sphincters so that we don't empty our bladder in this threatening situation. Stimulation is a result of alpha-1 adrenergic stimulation. I want to make certain that I'm absolutely clear here. When the sympathetic nervous system is activated and the neurons release norepinephrine at the synapse, the norepinephrine comes across and binds to adrenergic receptors on all of these tissues that I'm talking about. The types of receptors in particular tissues varies. Some tissues have one type of adrenergic receptor, some tissues have several types of adrenergic receptors, but most tissues have one type of adrenergic receptor that is predominant in that tissue. So for instance, when we're talking about the urinary bladder and we're talking about specifically the detrusor muscle in the urinary bladder, the major predominant type of adrenergic receptor in that detrusor muscle are beta 2 receptors. When the sympathetic nervous system is stimulated, norepinephrine is released. When norepinephrine binds to the beta 2 receptor on the detrusor muscle, the detrusor muscle's activity is inhibited. So I want to make sure that you're following exactly what I mean when I'm saying sympathetic stimulation, but effector organ inhibition. Things get a little bit tricky when you get to the reproductive system. Ejaculation is the result of sympathetic nervous system stimulation. Therefore, the predominant receptor type present there are alpha-1 receptors. However, it would not be helpful in a fight or flight situation. The good thing is that in order for ejaculation to occur, erection has to be present first, which is the result of parasympathetic activation. So if the parasympathetic is not there first, which usually is not in a fight or flight situation, then you don't have to be worried about being bothered by ejaculation as a result of alpha-1 adrenergic stimulation. Uterine contraction would not be helpful in a fight or flight situation. Therefore, sympathetic activation resulting in norepinephrine release causes relaxation or inhibition of the myometrial layer of the uterus. Inhibition is the result of primarily beta 2 adrenergic receptors. When the uterus is pregnant, however, and you want to deliver the baby, you want the myometrial cells to contract. Alpha-1 stimulation results in myometrial contraction. Of course, we know that there are other hormones responsible for uterine contractions at the time of delivery, oxytocin, prostaglandins, but there is a little bit of sympathetic stimulation in the form of alpha-1 receptor stimulation that also causes or contributes to uterine contraction. When it's not time to deliver the baby, but the uterus is pregnant, beta 2 receptors are responsible for inhibiting the smooth muscle contraction. So both alpha-1 receptors and beta 2 receptors are present in the pregnant uterus. We can take advantage of the presence of beta 2 receptors in a patient who is experiencing premature labor. We can administer beta 2 agonist drugs to stimulate those beta 2 receptors and inhibit myometrial cell contraction to stop premature labor. Looking at our fat cells or our adipocytes, we need to mobilize the energy that's stored in these adipocytes in a fight or flight situation. So sympathetic stimulation will stimulate the beta 1 and modified beta 1 receptors called beta 3 receptors on lipocytes to stimulate the process of lipolysis, which is breakdown of the stored fats to mobilize fatty acids and glycerol, which can be used to provide energy. Our liver is constantly storing excess glucose in the form of glycogen. The process is called glycogenesis. Well, in a fight or flight situation, like we said in the previous slide, we need to mobilize all of our extra resources that can provide energy for us. So we need to stop storing glycogen, and in fact, we need to break down our stored glycogen to use for energy. There's also a process called gluconeogenesis that occurs in the liver, and I would advise you as you go through all of the program, whenever there's a new word that you don't necessarily understand or have never come across before, break the word down. Gluconeogenesis. Genesis is creation, neo is new, glucose refers to glucose. So the process of gluconeogenesis is actually creating energy sources or creating new glucose from non-glucose substances such as proteins and fats. So when the sympathetic nervous system is activated, the process of storing glycogen is inhibited, and that process is inhibited by stimulation of beta 2 receptors in the liver. And we need to mobilize our stored energy resources. So the processes of glycogenolysis, or the breakdown of glycogen, and the creation of new glucose, gluconeogenesis, are both stimulated. They are stimulated by alpha-1 activation. Remember that our skeletal muscles also store glycogen, and that glycogen will definitely be needed by the skeletal muscles as energy or fuel to flee the situation. So our skeletal muscles will also undergo the process of glycogenolysis. So glycogenesis is inhibited by sympathetic activation of beta-2 receptors. Skeletal muscles have lots of sodium potassium ATPase pumps, and those ATPase pumps are going to need to be stimulated to provide the energy for our muscles so we can run away from the situation. Whenever sodium potassium ATPase pumps are stimulated, there's an increase in potassium and our serum potassium will decrease. This is done by beta-2. And I put the kind of star around the beta-2 because this is an exception to the rule that we talked about when we first started talking about the adrenergic receptor subtypes. Remember that glucose and potassium move together, so we're moving glucose into the skeletal muscle cells, and potassium is also going to move in, which is going to decrease our serum potassium. You may wonder why you have a tendency to have tremors or to shake when you're frightened. This is because our muscle spindles are under the control of our sympathetic nervous system. Beta-2 receptors actually maintain the balance between our flexors and our extensors, and for whatever reason, when we have a massive sympathetic outflow, our muscle spindles are inhibited by the massive sympathetic stimulation of beta-2 receptors, and tremors occur. The juxtaglomerular apparatus in our kidneys is responsible for releasing renin. And definitely we want to release renin in a fight or flight situation because renin combines with angiotensinogen to become angiotensin 1. Angiotensin 1 gets converted to angiotensin 2 in the lungs, and angiotensin 2 is a very potent vasoconstrictor. This is preparing us to stop bleeding in case we are injured in this threatening situation. And there are alpha-2 receptors on our platelets. When alpha-2 receptors on the platelets are stimulated by sympathetic outflow, it causes platelet aggregation in preparation to stop bleeding again, like we said in the previous slide. I'm going to stop here because the video is getting longer than I anticipated. The purpose of this video was to refresh your memory about the autonomic nervous system. I know all of you covered the autonomic nervous system in your undergraduate education, some of you that may have been more recently than others, and I've also learned that some nursing schools cover this in more or less detail. The autonomic nervous system is so important to everything we do in anesthesia. To give you just a couple of many examples, if your patient became tachycardic in the operating room, after you've determined that the problem is not light anesthesia, you may choose to treat the tachycardia by choosing a drug that works on the autonomic nervous system. Now that you know that the primary adrenergic receptors in the heart are beta-1 receptors, you know to choose a beta-1 blocker. It also applies when you're doing regional anesthesia. If you did a spinal anesthetic, injecting local anesthetic into the cerebral spinal fluid, that local anesthetic blocks nerve impulses of both your sensory fibers and the autonomic fibers. When you're taught to measure at what level the sensory fibers are blocked, you'll also be taught in relation to those sensory fibers which level the autonomics are blocked. Now that you know that the sympathetic fibers originate in the thoracic and lumbar spine, you will be able to predict the consequences of the blockade of those autonomic fibers. So I hope you'd enjoyed this, and I hope you take some time to really work on this material and commit it to memory. The whole purpose is about giving you a head start and putting you at an advantage when you come into the program. So take advantage of it and let me know if you have questions. I look forward to seeing you in the fall.